All right. So I'll make it official. So thank you for joining me today. And I'm excited to be speaking with Dr. Michael Daniels. He's the founder of We Treat Feet Podiatry, one of Maryland's leading podiatry groups known for their patient first approach. Dr. Daniels, welcome to the podcast.
Thank you for having me.
Not a problem. All right. So today, just a couple things I want to discuss. I'd like to focus on, your story, a couple background questions, discuss some of the biggest wins that you've been involved with, and working strategies that helped your business just succeed to the growth that it's made today. All righty?
Absolutely. Happy to discuss it.
All right. So we'll start with the origin story, I like to call it. So what inspired you to start We Treat Feet Podiatry?
I finished residency in 2002 and I joined a practice with a gentleman who had been sitting in his office by himself for about 30 years. After about 2 years, I was making more money than he was, so I took a pay cut to become a partner. And then 2 years later, bought him out. He left a year after that. And when I bought him out, I started acquiring practices. As a new associate, when I would look and see, what the revenue numbers were coming in and how little I was getting, I realized, hey, I might want to have some associates someday. So that was kind of my initial goal. Had no idea what I was doing, but started buying practices. To date, I've bought 12 practices and combined them into what is now our current. Some where we had doctors that stayed for a very short period of time, some where we had doctors stay for several years. Sometime around 2010, I always say it was right about the time I hit seven figures in revenue, and I thought I was the bomb.
Hmm.
I said, okay, I really don't know what I'm doing. So I went back and I got an MBA degree online just to kind of get a notion of what I was doing. And the only thing that the MBA really taught me was that I really had no idea what I was doing, and I was really flying by the seat of my pants. I've spent since 2014, I think I finished. I've spent every day trying to become more data focused in the practice approach. And part of the problem is it just never really happens because I try to set time aside to do administrative work. And then the clinical side just keeps pulling me back in. It's like Michael Corleone, you just keep pulling me back in.
That's it. That's it.
And I get sidetracked. So, sitting on my desk here, I have about seven different projects that I say, oh, I'm going to work on that. But there are still only 24 hours in a day, although if you can find a 25th, I would be really grateful if you'd share. And I just don't get to it. Like right before we started this conversation, I'm sitting here documenting from my patients from today. So it's a never-ending battle between, patient care and, growth of the business. And that's kind of how I got to where I am today.
Oh, that's it hits at home, so I understand completely. I started this podcast, but I had the medical background, so patient care is always there. The patients start funneling. Now it's what, 13 years, right? You said 2000, no, 23 years it was. You said 2002, right?
I
Yeah,
did.
so that's phenomenal. 12 practices later. Well, congratulations. It seems like you got the ball rolling, so that's awesome to hear.
I am the victim of be careful what you wish for. You just might get it.
All right, all right. Well, so now, I guess you kind of touched on this one, so I'm going to skip on. My next one was going to be how's the practice evolved since its founding, but you pretty much nailed on that on full cylinders, right?
Thank you.
So with the team of over 100 years of combined, I think actually it was on your website yesterday. I think it's over 200 years of combined. I saw at the bottom, right, of years experience. How do you, as the founder, the CEO, how do you maintain like expertise across all those sites?
I will tell you, it is incredibly difficult. One of the philosophies I've always had, and this might relate to my own personal belief, is we try not to have an office for a doctor. We try to make sure that there are at least two doctors that go to a particular office, and that's good process. If somebody leaves, the patients aren't seeing somebody new completely, or if somebody leaves, you're not abandoning that office and letting it sit open while you're waiting for another physician to be able to come in and start. So, we do that in the sense that, at least we have more than one doctor in basically every office. We do meet quarterly as a physician team. We meet with our admins to discuss things. I myself, I try very, very hard not to send out more than one email a week to the doctors, and even then they don't read them sometimes. But I am, kind of a news junkie, so I'm the one who reads all the junk email that comes to me every day, which is why it takes me an hour and a half to go through my email every morning. But occasionally you get, pearls that really kind of help and really kind of hit home. Things specifically also about, Medicare in regards to documentation, or, new processes that are coming down the pike, or what people are saying. So for example, before we started talking today, I was actually sitting in on a meeting with a company where, and they can remain nameless, but they were talking about ambient listening technologies and saving doctors 93% of their time because they were talking about how they were spending 15 minutes with a patient and then 15 minutes documenting, and now they have the documentation down to 1 minute using AI. We've been using ambient listening in our practice for a good year now. I think I started using it. I was a very, very early adopter, working just with a very small company out in California. And it hallucinates all the time. I have been creating a list. I will someday be starting a Twitter handle that says "Poopy My AI says." I will spare you the expletive here, because it says some really weird things, and sometimes it says things that are just not true. Or what I see a lot of is my family and I did a trip to Japan this summer, and my patients are asking about it, but my AI thinks all of my patients went to Japan and
Yeah.
keeps telling me about my patients' trips to Japan when they weren't. They were my trip. So you get stuff like that. So then when they're talking about, okay, well, you see the patient and 1 minute later it's done, you just hit save and you move on to the next one. I'm like, well, no, you got to read it. And I even asked in the chat, I'm like, we all know about hallucinations. And the answer was inappropriate. It was like, oh, well, we know it's not perfect and we just know that's going to be there. Well, you have to understand in medicine, the standard for documentation is perfection. If you have a Medicare LCD and it requires 12 things and 11 are fine and one is wrong, they will take the money back. It's an unreasonable and impossible standard to have to live up to. Yet we as physicians have to do that. And they're saying, well, as long as it's close enough,
Yeah. No.
is not going to be very good. I can only imagine what some gifted trial attorney would say to them when their note says they did something they didn't do, and you say, "Oh, well, AI said that," and the next response is, "Well, how much else of this note is not true that AI made up?"
Yep.
And all your credibility is out the window. So I find that a little bit problematic in that sense that we're so relying on this technology. I happen to love my ambient listening because it really goes back and reflects in my mind everything I did during the visit. But it takes me much longer to do notes now that I'm doing it. But my notes are ridiculously long; they look like novels.
Yeah. Because you have to go back
Where
and proofread everything, make sure
I
there's no
have
mistakes or any hiccups
a-
there.
and I can't read every word. It's just not possible, but I skim everything and looking for things, and you start to kind of realize where it makes mistakes. So you start to know where to focus in. But it's those sort of things that really kind of we try to disseminate to doctors because it's so easy for doctors to hit cut paste sign and not read anything. And you see it throughout all of medicine. We do a lot of inpatient work, a lot of lower extremity wounds and infections. And, some of the notes written by some of my colleagues are just, for lack of a better term, junk. They don't say anything. There's no usable information in there. And, it's just kind of repeated the same thing every day, review of the labs and, keep doing this, keep doing that, blah, blah, blah. It's hard. I mean, it does require you to actually interact with people to really know what's going on. And I talk to especially my infectious disease colleagues and my medicine colleagues all the time for my hospital patients. PT is another one. We talk to the physical therapists and occupational therapists a lot, getting those patients up. I'm a lower extremity specialist. I deal with foot and leg wounds. Can they walk is a very big issue in my world. But the other thing is a lot of people don't read the notes because I put it in my notes.
Of
Yet I
course, of
still get
course.
messages and calls. Hey, what's the weight bearing status for this patient? So I try to write orders for it, but then even when I write orders for it, sometimes it's not seen. So you got these problems with these technologies where it's made life faster. It has not made life better. And I tell my doctors that and try to make sure that they know the information and that they try to do it correctly. That's a long-winded way of answering your question.
Yeah, no, no. Listen, that's what we're here for, right? We're here for discussion to put this out there. So it's good. I love it. So now maybe even besides talking about just maybe AI, all right, let's keep AI out of it. Are there any other emerging technologies that you see shaping the future of podiatry?
So it's funny because podiatry, I think, has evolved to the part where finding new stuff is very difficult, but improving old stuff is very prevalent. Right now, the big thing is all of these small, either minimally invasive and or jigs for doing standard podiatry procedures, bunions or simple midfoot fusions or ankle repairs. Total ankle replacements have really come a long way since they were brand new when I was a resident, and all of them seem to fail. And now they've become very, very commonplace, and they seem to be much more durable than they were. So those technologies are emerging. Where I think the emerging technology really is in things like light therapy for treatment of either pain issues or infectious issues, whether it be fungal or bacterial. I think diagnostic improvements, like for example, 2 years ago, we put a PCR lab into our office so we could get more rapid fungal and bacterial cultures. I mean, it was taking a week to 10 days to get a bacterial culture. If you're waiting on that for an antibiotic, the patient's dead.
Yeah, exactly.
Now we get them overnight, so it's much better. So those sort of things, and then the way to kind of streamline practice. How do we get patients in and out of the office in an efficient way without them feeling like we're just a factory? And there's been a big change in the mindset of physicians. I think every generation sits here and says, "Well, those young whippersnappers, they don't know what they're doing, and they have it so good." And I'm sure the generation before me said it about mine. But there has been a cosmetic. There's been a cosmic shift in, I think, lifestyle choices that people are making post-pandemic, especially younger people who spent maybe college years or medical school years or residency years in a pandemic where they had no social interactions outside. And they're starting to value these, social experiences, whether it be travel or friends or whatnot, much more so than they ever did because they spent 2 or 3 years not having it. My older son just graduated from college. He spent his junior and senior year in high school during the pandemic. My younger son, he was, seventh, eighth grade middle school. Middle school. He just went to college recently, and they have missed out on some of that socialization. So I think where I would consider myself a workaholic, and my patients always come first, and work is done before I do anything else. That is kind of disappearing. That's a good thing maybe for people, but for patients, it poses a problem. And my colleagues who are my age now, we all sit around going, "Oh my goodness, who's going to take care of us when we're old?" Because somebody who says, "I got to be out of here at 6 o'clock, I got a date,"
Yeah.
and people don't get sick 9 to 5. It's not a business hour kind of job. So that's the kind of stuff that's coming down that really it'll shake out eventually somehow, but sometimes it scares me.
Listen, I guess I might be considered like from the younger generation. I don't mind sharing my name. I'm 34 years old, but so I have this podcast, right? It's new. We just launched it, the Rivera AI solutions and whatnot. But my background, just a little bit, not to take it away from you at all. I'm in radiology. I'm the technical director. That's my full time of Stony Brook Advanced Imaging. So I oversee a radiology clinic. I have 4 different offices, and hiring people these days, like you said, it just hits at home so much with the patient care. It's like I left the hospital. I worked there for 8 years, put my dues in. Now I've been in this position for about 3 years. You just don't find the people who it's like, oh, this person's late. And you don't know what happened. What happened at home? They need this test to go back to work. The younger generation does not see it that way. It's like you said, I have a 6 o'clock dinner reservation. Now I'm behind my schedule. Now I'm not going to get out there. So that hits at home, that answer for me. So it's definitely scary. It's worrisome, but I'd like to think I'm the outlier of the younger generation, if that's all right.
Listen, I say all the time, I love my radiology colleagues, but sometimes they're the bane of my existence.
Yeah,
Um,
that's what
I,
we get.
the chief of radiology in my system has become my friend because when things are not read right, listen, I read x-rays, all foot x-rays all day long. I probably do 10 or 15 on a slow day every single day of the week. Not a day goes by I don't look at them. So when our radiologists are reading foot x-rays and they read 1 or 2 a day, I get it. So I send them when when there's stuff that I don't agree with or concern, I always send it to the chief and say, "Listen, can you take a look at this and tell me what you think? Because I think this is missing." And 99 times out of 100, yeah, there's something there. Today I had one where I had normal alignment and there's a dislocated toe. It turns out it doesn't matter in this particular case, but I went back to the previous images and it's clearly different. So little things along those lines. But there are some serious problems too, and that is when it comes to radiology, is the radiologists are the experts. And there's so much of an expert that the younger generation really isn't spending time figuring out how to look at these, and they're just relying on the reports. And listen, radiologists are human like everybody else. From time to time, they're going to make a mistake. They're going to miss things. So I always look at them figuring, well, that's two opinions. Two opinions better than one opinion. At least now you have two of them. Because I had a case last year where the radiologist missed a very serious infection and they sent the patient home and it resulted in loss of a limb. So, the fact that the ED docs sent that patient home because the radiology report was negative and they
Yep.
didn't look at the images or didn't know how to look at the images. And listen, no busting on the ED docs. They have the worst job in the world. Why anybody good in third year of medical school does ED and goes, wow, I want to do this for the rest of my life, blows my mind. I mean, you see the people at worst. They're hurt, they're scared, they're abused, they're beaten. It's awful. I don't know how they don't go home and cry themselves to sleep. I look at feet all day long. I go home and take the paper clip off my nose and I'm good to go. Um, but it's one of those things where the as we become more and more and more specialized in medicine and more focused, we've lost the bigger picture. And sometimes that's a little scary because you're relying on other people to make clinical decisions that affect your clinical decisions. And these problems just start stacking on each other. It's kind of like with electronic medical records. The biggest problem with electronic medical records is once there's a mistake in there, you get it out, you fix it, go ahead.
Yep.
But it's duplicated 400 times. So everybody's going back and adding addendums everywhere and those sort of things. And, if you have a patient who finds one and is very, upset about it, it can be a fairly significant problem. And it does happen. You click the wrong button. They're all right next to each other. So this technology that we have and this dependence on it is becoming more and more of an issue. One of the biggest things I have is when patients who get unneeded radiology tests for obvious diagnoses. And I'll give you the prime example. If you can touch a bone in a wound, it's 91% chance it's osteomyelitis. All right. That was 1985, that report came out. Okay. So it's better now. I can't tell you how many times they want to order MRIs to rule out osteomyelitis when you're staring at a bone that is sticking out of a person's foot. And my rule is it's never good to have your insides on the outside. So if your insides are on the outside, that's a problem. You probably don't need $1,000 MRI to know that you need to do something about that bone infection. And you're probably not going to be able to treat it medically because, it's outside.
Oh,
I don't know about you, but I haven't stuck any of my bones back in my body anytime recently. So I doubt you have, but it's little things like that. It's because, they're just the radiologists like they do. They don't see the patients. So they say, well, this test might be more effective or consider doing this for this diagnosis or, good, solid, medicine work that they do because they don't have the opportunity to see the patients. And most of the time they don't have the opportunity to review medical records. But again, they get reports and they're negative, and they say, "Well, this is more sensitive," so now they're ordering a second test.
mhm.
It's one of these bizarre processes, and it goes back to the new way that medicine's being practiced, and then the medical legal issues that are associated with practice these days, and the CYA mentality that all physicians have to have, because every time you turn on the dinner table, you see an ad on TV for Dewey, Scrum, and Hal.
Yep. Yep.
So you got to practice defensively, and it's an issue, and it's actually slows down care sometimes.
No, absolutely. That's well, you speak in my language with the osteomyelitis, the MRIs, the over ordering of imaging. It really is the old school. I was never there, but it's how many chest X-rays for a placement of an ET tube or an NG tube, right? What about a stethoscope? And I'm not a doctor, nothing to do with that. How about a stethoscope and breathing? And it's they come into the ER and we order imaging as a tool of medicine. And like you said, to your point, it's definitely getting a little overused. I don't want to use the word abusive. Overused, we'll go with, right?
Our radiologist will tell you straight out that, there are too many CT scans ordered. Because my thing is if you're dealing with a diabetic foot infection, the first thing I want is an X-ray. Because probably 95% of the time, that's all I need to be able to make a diagnosis and treat the patient. Because I know exactly what I'm looking for. But you do get false positives with CT or false negatives, but you get a bunch with MRI. And MRI is considered the gold standard for osteomyelitis and bone infections. But the big problem is marrow edema, trauma or fracture and infection can all look the same. So unless you have a really, really good radiologist who takes the time to really kind of review it and discuss it in detail, it's a little wrong. I mean, basically, when you have a foot and if you don't have any cortical disruption of the bone, but your MRI, but you have marrow edema, they'll call it osteo all day long, and it's not. It's pressure. It's retrograde pressure a lot of times. That's why they get the ulcers in the first place. The worst ones are the patients who have just have DTIs or deep tissue injuries on their heels. So they have these purple spots. There's no open wound. It's all just pressure. And they get these MRIs, and the MRIs are read as positive for osteo because the same thing that caused the ulcer caused the pressure on the bone. And now you get these poor people who are mostly bedbound anyway, who end up on 8 weeks of IV antibiotics because of a positive MRI. It's
Yeah.
either that or go do a bone biopsy and take a piece of bone out to send for culture in patients who are pretty sick. So, you kind of get stuck in a corner with some of these things. And that's kind of one of the issues that we see going back to the young guys, because that's all how they're trained. They just order tests, order tests, order tests. It's not as much fundamental, physical exam components. When I started my career, there was an older general surgeon, Dr. J. Carpa, who passed away many years ago already. And, he went to medical school in the late 50s, early 60s when X-ray was it. That's all they had.
Is it?
So he was an amazing dietitian because he had to be back then.
Yeah. Yep.
I don't think the guy ever ordered anything but an MRI. Sorry, but an X-ray. I don't think he
Exactly.
ever ordered an MRI in his career.
Back in the
Um,
plain film days, right?
but
Dark rooms and
he
all
was
that.
right, and he was amazing. And I'll tell you, when we had weird cases and nobody else knew what was going on, Harpa knew.
He was the one.
He
Yeah.
was a smart cookie. He really was. I missed him. He was funny too. I miss him. He was a great guy.
That's awesome. That's great. So I know kind of touched on them a little bit, with the younger generation and whatnot, but are there any other key challenges that you see in the growing medical practice?
Well, the one of the things you see in medicine in general is the lack of doctors actually going into practice. There is huge opportunities in research, so a lot of them go into research. And on the call, I was just the lecture I was just sitting in. It was done by a doctor who doesn't practice. He's a tech guy, and his expertise is the tech of the practice, so he helps practitioners. But he doesn't practice, so that's one less physician to actually see patients. Although his whole thing is to try to get doctors to be able to see more patients with less documentation. So he's
Uh,
trying to make up for it. But we see a lot of doctors in private equity nowadays. You do because they are generally fairly smart people, and you can teach them most things. We see doctors that just don't do it anymore. A guy I went to high school with, who I probably have not seen since high school, but thanks to Facebook, I know what's going on with him. Is an anesthesiologist. He just quit anesthesiology to become a financial planner.
wow.
I don't know why. He just posted it on Facebook one day, and I'm like, really? And he'd written a textbook a couple of years ago. He was all proud. He pushed on Facebook that he'd done a textbook on anesthesiology. And I was all like, hey, I know Scott. He was a good guy in high school. Um, he's not doing it anymore. So that's one less anesthesiologist, which means that's one more surgical case that's going to have to wait because there's not an anesthesiologist. And that's the biggest thing that we see. There's not enough medical schools. Applications to medical school are down. I do jokingly say most of the time, if you're smart enough to get into medical school, you're probably smart enough not to go
Yeah.
because right now it's going to cost you $300,000 to get a degree. Do
Yeah.
you know what you're going to make as a physician 10 years from now? Probably less than we're making now. And that's a scary thought. That's a house. $300,000. That's a house payment before you even have a place to live of your student loans as a new doctor. So it's a scary proposition. It really is. And neither one of my kids have gone and have followed my footsteps, both of which my older son graduated as a mechanical engineer. My younger son's in a bachelor master's program for mechanical engineering.
Okay.
And I tell this funny story because I love this story. It really kind of hits home as to what the problem is. My son, his freshman year in college, had to take Gen Chem 1 as part of his major for mechanical engineering. And he got an A in Gen Chem 1. Now, I'm a doctor. I didn't get an A in Gen Chem
Yeah.
1. Anyway, he got an A in Gen Chem 1. And the professor at the end of the semester came up to him and said, hey, Elliot, that's my son's name, you seem to have a really good knack for chemistry. Have you considered chemical engineering, which requires a lot more chemistry? And he told me, he looked at him, he said, no, my dad did organic chemistry. I'm not doing it. Nope. Thank you very much. And walked away. So I guess I've complained about organic chemistry enough during the course of his life
That was
that
it. Get an A and
that
I'm done.
he wasn't even considering chemical engineering. So, it's one of those things where, lots of people want to follow in their parents' footsteps, but you're not seeing that in medicine anymore because, the hours and, just I always tell people think I love my job because when I'm in a treatment room, I'm friendly, I'm personable, I'm not afraid to talk, as you can see. And that goes a long way with people today who are very skittish and don't look people in the eye and those sort of things that are beyond this conversation. But I tell people, I can't stand my job. The part you see is the only part I like. It's all the other stuff that's horrific. That's why I'm sitting here at, what is it, 3:30 in the afternoon. I finished patients at 1. I'm still writing notes.
Yeah. Yep. No,
you
I
know? So that, and then the billing and the regulation, and it's hard because you're in a profession as a doctor where the expectation is perfection. There is no, oh, sorry, you were close. There is no, oh, we'll get them next time. that's the standard. And there's a lot of ramifications if you don't hit that mark.
Yeah, no, it's patient care is the reason why we all got into it, right, in the first place. But like you said, everything on the back end, the tedious, the paperwork, the documentation, it's a lot. It's a lot, and it's nonstop. Like you said, 7 projects on the desk, and here we are. Just so I appreciate your time because I know it's valuable. So
Oh,
I'm very glad that you took some time out to have this conversation. I'm enjoying it. I hope you are as well.
yeah, no, I'm happy to talk about it.
So
Who
let's
doesn't want to talk about themselves for an hour? Come on.
yeah. So let's talk about the challenges. Let's maybe shed some light on like a patient success story. Could you like maybe a particular like memorable patient success story that sticks out to you over the course of your career?
So the focus of my clinical practice is wound care and limb salvage. So, I'm the guy who tries not to cut anything off, and I honestly believe there are far too many amputations done in this country that probably are avoidable. The issue with that is well, it's much cheaper a lot of times to do an amputation than to spend 6 months or a year trying to heal a wound. But then if you look at the long-term expenses of amputations and how devastating they are, not only to people financially, but the system, it's probably less expensive to treat them. But it's litigious and it's hard, and people don't understand and they get frustrated. So it's a very, very hard thing to do. And one thing that I hear two things fairly regularly that make me think, okay, I must be doing something right when it comes to these patients. One is when people say nobody ever told me that. And I'm not the first doctor they've ever seen. That's the first one. And two, when somebody says, "Oh, thank you. You're the only one who treats me like a person." And I go, "Well, that's because you're a patient, not a problem." Doctors now start treating patients as their problems, not people. And these are people who come to you for your help. And if you don't want to help them, you're in the wrong profession. And there are too many people who no longer they see patients as the enemy.
Hmm.
And they you can't do that. It's just it's an unhealthy way to live. But I could sit here and name, several dozen challenges where I've had people. My most recent one, a guy who came in yesterday, he had gone to a hospital with just foot infection. I mean, standard kind of run-of-the-mill foot infection, and they told him he needed his leg removed. And and I had seen him. I only saw him once before. Before this. Well, and he was fine. It was a month earlier. So he calls my office, freaking out, and we're like, "Well, you're in a hospital we don't go to. We can't help you. If you end up in a hospital where we can see you, we're happy to do that. Or if you can come to the office." So we ended up leaving that hospital,
Oh, wow.
AMA, and coming to our hospital, and um. He got discharged a couple days later. He still has both legs. He still has 10 toes. I got to remove pieces of the ends of the big ones, which isn't a great thing, but it's certainly not going to negatively impact his life significantly. And they were going to cut his leg off.
That quick. That quick.
Yeah. And again, some people I feel bad because whether or not it's intimidation or wherewithal or sometimes just, intellect are willing to go, "Oh, if you say so, okay, I guess that's what I need." When I think a lot of these are unnecessary, because it certainly would have been in this particular gentleman's case. And I've seen that multiple times. I have dozens of patients like that. Now, you have to understand a patient who is a train wreck is an easy patient for me because my patients are nightmares. They're amputees with Charcot dislocations and infections and osteo and weepy wounds and diabetic and A1Cs of 14. And I mean, you name it, they're a nightmare. They're all a mess. There's a little bit of more, savior complex when you can save something like that nobody
Yeah.
else either wanted to try. And again, I consider amputations a failure on my part. And even if there's nothing I could do differently, I'm like, well, this my job is to save the limb. And if it doesn't get saved for whatever reason, then I failed somewhere along the line. And it could have been in pre-problem education, or it could be in, during the problem trying to work harder on compliance. Or it could be just sometimes God did it. And sometimes you just can't fight the will of the will of the upstairs, the man upstairs. So to sit here and kind of rattle off specific things, I don't really consider what I've done in business per se to be one of my greater success stories. It's the cause of a lot of stress in my life. I do honestly believe it's probably going to put me in an early grave. So my wife and her second husband are going to live very well on my insurance money. Um, you know, but listen, I'm able to put my kids through school, and I look like I might someday be able to retire, maybe. And my car isn't a jalopy. So, I live in a decent neighborhood. I've done fine. I've done well. I'm a success story in the sense of life, and I'm grateful for what I have. But, every day I still have the woe is me. Oh my goodness, how am I going to get through the day thoughts?
Yeah.
Because, there's 25 or 30 patients on the schedule, and 20 of them have wounds, and 15 of them are at risk for amputation. And then, the electric bill comes every week, every month rather. The rent checks are always coming. I got payroll to meet every other week. My Medicare reimbursement got cut 2.83% this year. So my rent didn't go down. My rent went up 3%, but my Medicare got cut 2.8%. So, it gets harder and harder and harder. And from a practice management standpoint, the only way I have found to be able to combat that is one, higher volumes, which, again, you just get maxed out at some point. There's only so many patients you can see in a day. Or number two is finding, different service lines that we can bring into the business to help generate revenue to keep the lights on. And that's always been my process is what more can we do to generate revenue? And I'm not looking to do things for patients they don't need. What I'm looking to do is take the things that we were writing prescriptions or sending them out for and bring them into the office. So we do prescription drug dispensing in our office. I mentioned the PCR lab. We have x-rays in all of our offices. We do a lot of durable medical equipment, a lot of diagnostic stuff. Those sort of things are all alternate revenue. It's more than just what I can do in a treatment. That's where we look at it, and that's how I've been able to keep the doors open and been able to build a practice. But it gets harder and harder and harder every single year. And I look back on years ago with with amazement of how easy it was then compared to now. And I don't remember thinking it was easy at the time. So I take my solace, I take my successes in how my patients do, not how I do.
Gotcha. And do you ever see down the line maybe being, I mean, I know to me, my favorite part of the entire job that I do is patient care, right? And it seems like you're kind of the same way. Do you ever think about being hands off, not seeing patients, just kind of overseeing the entire business?
I do all the time. And I would probably do it in a heartbeat if the opportunity existed. The problem is, I'm the largest generator in our practice. Even when I had less patient hours, because technically for a long time I didn't have patient hours on Mondays and Fridays. Now I ended up rounding, I ended up in the OR, I ended up doing something, but still I didn't have the 30 patient Monday and the 30 patient Friday schedules that some of the other doctors had, and I would still generate more. And part of it is I take care of these patients who have many, many, many needs. So we're always doing equipment, we're always doing bracing, we're always doing shoes, we're always doing insert management. I mean, there's just tons of stuff that I do that people who are treating heel pain or fixing bunions don't necessarily do. But by the same token is I don't right now foresee a way that we would continue to exist, or that I could support myself if I didn't do my patient care, because again that's still our single largest source of revenue.
Yep, absolutely. So, next question might be, I don't know, maybe kind of easy for you, but I'm curious to see your point of view on it. So, what are common like misconceptions that you think the general public have about foot and ankle care?
My favorite is I can move it, it's not broken.
I knew it would be a good one. I like it.
Yeah, that's my favorite one. I can move it, it's not broken. Or there's a couple like that. Um, uh, it, the one that makes the most amount of sense that people say is, well, it's a little red, so it must be infected. You know,
That's
that's
what MD's for, right? That's
yeah,
everybody does.
that's it. So we get that one too. And I don't know why my toes got these wounds. My shoes fit just fine.
Yeah, yeah, perfect.
But as I can't feel them, I would feel if they're too tight, and all these people are neuropathic and have no sensation whatsoever. I mean, literally, a lot of these patients, you can actually amputate toes with no lack anesthetic with them wide awake, and they feel nothing. That's how bad neuropathy gets in a lot of these patients. So we get lots of misconceptions like that. I think one of the misconceptions or the misunderstanding is what as podiatrists, what our education is. Um, you know, because we have doctorates in podiatric medicine. We're not MDs, we're not DOs, we're not DDSs, we're not chiropractors, we're not optometrists. We are podiatrists, and we do a full medical school training basically with some minor changes. Like I didn't have to do OB and what I didn't have to do. I didn't have to do OB, and I didn't have to do an inpatient psych month, which I'm very grateful. I did an outpatient psych course. I'm very
Nice.
grateful for that because that is the wrong soul. Um, but and then we go through and we do surgical residencies. And these days, all of the podiatric residencies are now 3 years. when I trained, it was two. I did 2 years was standard. There were still 1 year programs. There are lots of doctors out there only 1 year training. So the new guys coming out are getting a lot of training and a lot of hospital experience, which gives them a lot of opportunity to order tests. Keep your radiology guys busy.
Yeah, yeah,
Uh,
yeah.
um, but the amount of training that we get, people don't understand. And they use arbitrary ways to try to classify us as and try to kind of put us into holes. We work very closely. I work very closely with my vascular surgeon colleagues. I talk to them every day. I think I have like a bat signal. Sometimes they just light up and they show up. Because again, all my patients need to go to vascular basically. I work well with my ortho colleagues. I'm a wound guy. I'm not a trauma guy. So I don't really interact with them at all. They when their incisions don't heal, they send them to me and I'm happy to heal them. When the ankle, like we have a patient now with an ankle wound who's got an ankle fracture. They're dealing with the ankle fracture. I'm just dealing with a wound. I'm like,
Of
they can
course.
have it. It's an 89-year-old woman who, is tremendously, hasn't walked in years. So she's got osteoporosis and she fell, which is how the ankle got broken. And I'm like, well, I don't want to deal with that. They can deal with that because, she's 89. She doesn't walk. Are you going to fix it? Sometimes I would look at that and I'd go, no. And they would say, oh, yeah, we're going to take it to the OR tomorrow. I'm like, okay,
Yeah.
but they're ortho. Let them do what they want. It's not that we don't do. I mean, I'll do ankle fractures every once in a while with some of my colleagues. I don't like to do that stuff. I really want to stay out of the OR. When you're new in practice and you're excited and you want to be the surgeon and you're in the OR time, it's like the thing. And then when you're my age, you're like, oh, not again.
Yeah.
Because it's a waste of time. And it's not the surgery, it's the time between the surgeries. It takes so long to go through surgeries. Like we put ambulatory surgical facilities in some of our offices so we can do cases in the office because, I can do 4 cases before 12 on a Friday in my office, which would take me 7 or 8 hours at the hospital to
Yeah.
do the same
Oh,
4 cases,
at minimum.
and it's probably 48 minutes of actual operating time to do that because most of the cases I do are real small. I've got an ADD in my older age, and if it takes more than 20 minutes, I just don't have the patience to do it anymore. That's why my visits with patients are pretty good because none of them are more than 20 minutes.
Yeah.
Everything's new. So, those sort of things are kind of where it is. And I think there's still too many turf wars in medicine, which is, what I want, not what's best for the patient. And there's still too many people that are motivated by the wrong things. And that doesn't necessarily mean they're motivated by money. Sometimes they're motivated by their research. Sometimes they're motivated by doing a particular procedure and they only want to do that. There are lots of people that consult for, product and manufacturing companies and they want to use that equipment because a lot of them are, one, help to design it. So they probably think it is better. And then number two, of course, are compensated for that. So it makes a lot of sense for them to do it. But if they're not using their stuff, to them that might be a waste of time, and they might want to not want to do it. And everything's become so specialized. I have a colleague who's a ophthalmologist, and last time I asked him how he was doing, he's like, "Man, it's getting tight out there. I'm only doing right eyes now." You know, so that's how specialized they're becoming. So that's kind of the whole kind of thing with medicine is I think there's a little bit more of a conjugal collegial aspect to it, but there's still too many people that are fighting turf wars that are unnecessary.
All right. So I'm going to get to it, skipping around a little bit because the conversation has been awesome. Loving it. Make me laugh. I think all the viewers are going to like it and enjoy it as well. So I'll start to work into the closing just to give you some time so you could answer how you'd like to. So, what advice would you give to other medical practices, like practice owners, looking to grow while maintaining that excellence and patient care that you always keep at the forefront?
You have to know not only what your financials are, but how to produce them, how to read them, and how to react based on them. Running a business is tough, and cash flow is everything. And part of the problem is if you don't know what you're looking at in an income statement or a balance sheet, you can think you're doing really well when you're really not. And I had that early in my career where my report said I was doing just great, but I'm like, well, why do I feel like I never have any money? And again, it all has to do with, the relationship between, the income statement and the balance sheet, especially if you use debt to finance your acquisitions, which, in my position, I had no other option. I didn't have investors. I still don't have investors. So, that's the one thing. The number two thing is you have to know how to delegate. Okay, you cannot sit here. I cannot be the one ordering gauze pads and dealing with the maid service and making sure the lawn is cut. There's just some things that I need off of my plate that I can't do because I'm too busy seeing patients. So you need to be able to delegate, and you need a certain level I call of mid-management. Even if you think about it, days of or you had the doctor in the office, and you probably had the medical assistant, the front desk person, and a back office person. That was while most offices ran. And that back office person was like the middle management or the office manager per se. And as you've grown bigger, that kind of started to kind of evaporate away, but you still need that middle level because, like for example, I don't hire and fire front desk people or medical assistants. I I have nothing to do. I don't do their performance evaluations. I don't give them raises. I don't do anything having to do with them. And when I have a problem with them, I go to the person in our practice who handles them, and I give her my opinion, which sometimes can be a little harsh, but I give it to her because it's her job to deal with it. It's not my job because I mean, we have 50 employees. How am I going to be hiring and firing, 11 front desk people, or dealing with them, or dealing with somebody who steals, or dealing with someone who seems to be very, very sick. I joke all the time that I have the sickest staff ever. They're out all the time. I've
Mhm.
never seen people be sick as much as my staff. They seem to get very sick on very beautiful days in the spring. It's kind of funny. Hmm.
Oh yeah, oh yeah.
Um, so
We can
so I
know.
so I don't do that. So where I limit my involvement is I see my patients, so I have my patient care aspect. I am the chief medical officer, so that means I am the one who evaluates all of the stuff we use, whether it be DME equipment, whether it be supplies, whether it be new hardware, anything along those lines that's going to affect patient care. That falls under my responsibility. The hiring and firing of doctors, fortunately, I don't fire doctors hardly ever, but the hiring and firing of doctors is under my purview. And I'm the one who has to deal with fairly significant complications that arise with one of our doctors when patients are willing to let us to continue to take care of it. Because, sometimes patients get angry at a doctor and they don't see anybody in that practice. The whole practice is bad. So, but for people who are willing to, allow us to try to make it right, they usually end up with me, because I seem to be the one with the most amount of experience who, tries to talk people off the ledge. So that's it. And then the last thing I do is I handle all the financial aspects of the practice. So I pay all the bills, and I, make sure the financial reports, and I deal with accounting. That harkens back to years ago when we had a person stealing from us who, had too much access. So I limit access to, who has the money. Nobody has the ability to both spend and pay for something. So, if they have authorization to buy stuff, they're not paying for it. It's going, on a credit card, for example, where I'm seeing that. Or if they're seeing the credit card statements, they don't have the ability to buy anything themselves. So, they can't hide anything. So that's been my safeguard. Um, I wish I had a chief financial officer who could handle all that for me because it's a lot of work. I spend a lot of weekends doing stuff like that, sitting here going through, looking through credit card statements to find, the one charge that might not be appropriate.
Yeah.
Because again, and I will send emails. What are these charges? Why are these here and what are they, to try to make sure that we're doing them. And the other thing is to make sure that those charges are getting accurately reflected in our P&L. Amazed how if I don't say anything, the accountants just kind of plug anything anywhere they want. And you got these, well, how come you spent this much money on the gauze pad company? It's more than you ever spent before. I'm like, oh, well, because we bought a machine that makes gauze pads, and it's just stuck in the same place. So those sort of issues are what we do, and that's kind of how we run the practice as that. So I don't deal with HR HR stuff. I don't deal with phone complaints, or employee complaints. I don't take meetings routinely with vendors, or suppliers. I don't usually negotiate contracts, those sort of things. That all gets kind of feted out to accounting or legal or to the middle management staff that we have doing that. And then, from another point, when we got this big, we actually divided the company into two halves, and we have administrators, one for each half, who are responsible for everything in their halves. So they answer to, our operations people, and our operations people answer to me. And that's kind of how we set our hierarchy.
All right. Okay. All right. So I guess tell the people where they can learn more about We Treat Feet Podiatry.
Well, I jokingly tell people they can find me at the post office on the wall with those nine other guys. But that being aside, I mean, we're at WeTreatFeet.com. Very, very simple. I'm available on LinkedIn if people want to reach out to me. I do on my spare, in all my spare time, I do, some consulting work. So, I've worked with venture capital and private equity regarding, different things in medicine or podiatry. I do some minor business consulting as well. Again, people, I have letters by my name, so people think I know something. And listen, I'm just trying to make it until I get to retirement. I don't know when that's going to be, but I'm hoping it's going to be someday.
Okay. All right. Well, listen, it was an absolute pleasure. I love the conversation. I hope you enjoyed it as well. The insights made some really good points. It was real life challenges. I'm sure everybody's going to connect to it. I know you connected with me on a bunch of your point of views and thought process. So I just want to thank you for your time and, keep it up. Keep up the good work. We appreciate everything you're doing out there. And if you have any other final statements, now is the floor is yours.
Well, I appreciate you having me and letting me babble on here for about 45 minutes. I wish you the best of luck with this. We do need people discussing these issues. The only thing I can say is, the land of private practice or independent physician practices is getting smaller and smaller. And last year, and the year before, we finally went under 50% of physicians working in private practices. So now greater than 50% of physicians are employed with health systems or large medical firms or private equity. So we're dying out. I'm a dinosaur. We're dying out. And listen, someday I will sell to somebody, and it probably won't be another doctor. It'll probably be some organization, and that's just the way it's going. And I think that's kind of detrimental because, the loss of entrepreneurial spirit in private practice is kind of going to be a hard thing for people to understand because the people who are entrepreneurial aren't practicing anymore. They're working for tech companies. They're working for Wall Street. They're off, writing books or saving the world, doing other things that are important. I don't want to think those things aren't important, but the days of your doctor hanging a shingle and sitting in an office for 30 years are over. It
Yeah.
just doesn't happen anymore. So, I hope there's a pendulum swing the other way and the patients start to become more and more and more of the focus because that's kind of everybody wants the patients to be the focus. But, we're swinging the wrong way right now and we really do need to correct. And we will. I mean, it happens from time to time. They said the same thing in the 80s when HMOs came into being. So, but yeah, I mean, again, I do worry sometimes about the people who are, starting their careers as opposed to me, where I have more years behind me than ahead of me, because I worry about how they're going to make it. I really do. I don't know what's going to be there for them. But listen, I'm doing my part to try to, keep something that they can inherit, and hopefully the patients benefit from it.
Yeah. Yeah. All right. Well, one more time, thank you so much. All right, buddy. Dr. Michael Daniels, have a great day. All right. And thank you so
You
much again.
too. Thank you.
All right. Take care.
Take care.